The first speaker is Professor James DUCHARME. Jim is the immediate past president of International Federation of Emergency Medicine. He's also been taking many different roles in EM over the past years, including as the editor-in-chief in the Canadian Journal of Emergency Medicine for 11 years, as well as being external examiners for various specialty examinations across the world. He has also served in the corporate world, being a senior vice president and chief medical officer for different healthcare companies. So without further ado, Professor James DUCHARME.
All right, let's get started. So I would like to thank everyone from Hong Kong for inviting me to this meeting. I'm looking forward to giving a presentation that hopefully will stimulate your thoughts and allow everyone to have reflections on where we are going. We're going to be talking about emergency medicine in 2021, a global perspective, but more importantly, we're going to be talking about how things have changed and where we hope for them to go. We have to realize that things have been changed very much by COVID, but we're not yet certain how much that will change our entire practice. We have to realize that we are focused very, very much on the present, but there always has to be part of our attention spent on where we're going. And that's why the title of this conference is so important. A shout out to my good friends in Hong Kong and all the trainees who are there. Hopefully together in this next 20 minutes, we can talk about new frontiers and how can we advance care. Of course, when you talk about emergency medicine and where the future is and where we are today, it depends very much where you are. We could talk about being in Hong Kong. We could talk about the hospital I was working in up until February of this year that had an incredible computerized system in an entirely digital hospital. And that in 6 months succeeded in decreasing time to getting a patient admitted from the emergency department to the ward from 27 hours to less than 4 hours, simply by computerized control of bed usage. No change in personnel, no increased staffing, simply efficient use of what we have. We could talk about where I am now, 2 months later, where there are tents because of COVID in an old building that needs desperately to be rebuilt, but still practices quality emergency care. We could talk about being in Uganda, where the whole notion of aerosol control is impossible. We could talk about Tanzania, where a lot of medical care is given by people walking to clinics and who can only get the basic primary care, or they can be in the same country in very modern hospitals. So when we talk about the future of emergency medicine and where we are today, it clearly depends on where you are today. Unfortunately, when we talk about this, we have to sit there and point fingers at ourselves because we're failing to learn from the past. SARS hit the world in 2003. It was a coronavirus. It hit your country just like it hit my country, Canada. There were isolation measures that were required. We had to avoid nebulizations because of aerosolization of a droplet virus into an airborne virus. And we knew that there should be no crowding in the emergency departments because the first patient in Toronto started an outbreak because the patient was left in the hallway of an emergency department for 24 hours. The first person who contracted the disease from that patient was a nurse who was the first victim of SARS in Canada. And yet here we are 17 or 18 years later with another coronavirus. Incredibly, not a single measure learned from SARS was in place as a standard of care across a healthcare system in any country in the world. We learned nothing from SARS. We take a look at the annual death rate from tuberculosis of 1.5 million people, of 700,000 from malaria, both of which are treatable diseases, but we're not treating it. How many millions are going to die from COVID-19 and its variants? Will we learn at some point from these events? And of course, we continue to ignore other real problems in healthcare. I remember when the Ebola outbreak occurred in Africa, and Lee Wallace was very upset because he said, more people die in a single day in Africa from road traffic accidents than the entire death amount from the Ebola outbreak over several months. But no one talks about road traffic accidents in Africa. It's not newsworthy. There isn't a single system in the world that is health focused instead of illness focused. We don't focus on prevention and proper lifestyle. We focus on treatment after the fact. When we think about it, we should not have to see patients with asthma or migraines if prevention was the focus, because we would have prevented them from needing the emergency department. The question, of course, as emergency physicians is, how much of that is our responsibility? My answer to that question in 2021 is very different than it was 2 years ago. We have to recognize, and this has struck home to me on multiple occasions in the past few years, of the problem of low level of health education in the population. We talk that we have to speak and educate the level of grade 7 education in our emergency departments in North America, but in fact, our health education is even lower. People are against vaccinations because they believe they're dangerous. They misuse medications because they don't know how to use them, and they forget to use them because they haven't been properly instructed and don't understand the importance of them. There is obesity at an ever-growing rate in North America because we've allowed people to think it's okay to be obese. We haven't educated. We haven't provided the health education that we need to give. It isn't part of our inherent curriculum through all levels of school. So as I said, my answer changed over the last 2 years because I used to think that public health was something for somebody else to do. But public health and emergency medicine are inextricably entwined. And we need to realize this more and more. Let's look at public health measures and unintended consequences. Because of COVID, we shut down the economy in North America. But no one looked at the unintended consequences. There were millions of jobs lost or at least suspended. The problem was that for every million jobs lost, 40,000 people died unexpectedly. In other words, there was a 4% mortality for every million jobs lost, which was higher than the average COVID mortality rate at the same time. No one expected that. No one tried to do anything to prevent that. We just recognized that mental health issues were an increasing problem in society, that drinking was increasing in society, that there were all sorts of consequences to being shut down and shut in. We know that we think we have simple solutions, and it's very troubling to constantly listen to physician experts tell us how to manage the economy. We have to remember that solving system issues requires change management skills, most skills of which physicians do not have because they never took business training. It needs to have the ability to anticipate and respond to unintended consequences. It's a management skill that most physicians don't have. And so we end up with this. Even now, when the new variant is running through Ontario, Canada, with super saturated intensive care units and overwhelmed hospitals, we still don't get it. No matter what country you're in, at some point, the economy must be the priority ahead of healthcare. Because if not, the consequences of a dead economy will echo for decades and cause far more deaths indirectly than COVID could. What point is that? At what point do we reach that? I have no idea. But I admit I have no idea. And then, like many of our health experts who keep crying out for closing of systems and shutting down of things, not recognizing the consequences of thousands and thousands of jobs lost, of millions of jobs lost, of thousands of companies shut down forever. And the price we will have to pay as a result of those health decisions, the doctors will never pay the price for that. They will never accept that they were responsible for those long-reaching consequences. There has to be a balance. Again, I am not an expert. I can't tell you where that balance point is, but we are certainly not seeing it in many places. In 2021, we are, of course, in a virtual world. You're listening to me virtually. The International Conference for Emergency Medicine in Dubai is a virtual conference as a result, as have been so many others throughout this past year. So let's talk about our virtual world. We had to adapt it, we had to adopt it. But we haven't answered the question, is learning the same as with live education? Are we losing a generation of learners? Are they attending online but distracted and not listening? Of course, one could easily say, well, when you attend a conference, there's all sorts of people on their cell phones texting and messaging and all sorts of other things during a conference, so they're just as distracted there. I agree. When we have case discussions with medical students, and I have 10 students with me for a week to discuss a horizontal case, if I get 3 or 4 who participate in the discussion, I consider myself lucky. The others stay quiet. What are those others learning? Are they learning? We need to measure the actual learning experience. We need to make sure that we have a group that is developing as well as they should. That, of course, would have required that we had baseline data from previous years as to the rate and mapping of learning that they had, which sadly we don't have. Can virtual simulation setting recreate stress? I think of a case where I had a 13-year-old woman who came in having been thrown through a windshield because she didn't have her seatbelt on and had her carotid artery, her jugular vein, and her trachea transected. The next 5 to 10 minutes were some of the most stressful that I had ever lived in my life. How do you reproduce that? Oh my gosh, this 13-year-old is dying in front of me in a virtual setting when you know no one's dying. There's limited hands-on. Does it give us a better or a worse end product? So I asked this question without an answer. Would you trust a doctor with your stab wound but never laid hands on a real patient? Should you trust that physician? Again, I'm not sure. The virtual world of CPD. IFEM has already started doing this, trying to encourage people to participate in worldwide CPD events. At minimum cost, trying to encourage as many people to participate. It certainly provides greater access to learning for many who can't afford to travel. But it requires much more attention in detail to local biases. So what you're teaching may be very pertinent to people in, say, for example, Hong Kong, but have no relevance to people in Myanmar. It may be that the Hong Kong mindset or the white Western mindset is completely inappropriate for people in Central Africa. There are biases and privilege and Western mindset and misogyny and all sorts of other invisible curriculum items that need to be filtered out if you're going to open up and offer this to the world. So the question is, will it really open the door to people worldwide? Does it truly provide valid learning options for those unable to travel? Is it transferable knowledge to their environment? Can we adjust content for that purpose and still provide valid education to the local people who are participating? That's a very tough road to travel with lots of complexities. But we then ask ourselves, how necessary are on-site meetings for the purposes of CME? The answer is not very, but then that's not why I go to meetings. I go to meetings to hear people's clinical experience, to ask them questions about how their research has impacted their clinical practice, to make me comfortable going back home and introducing new medical directives and protocols at home. It gets me seeing different systems from different people's viewpoints that may make me want to come home and change things where I am. I can't do that in the virtual world right now. Are we the same? Well, we're not traveling anywhere near as much as we used to. And traveling allows us to see other systems and opportunities. We know that external expertise can provide focused suggestions to improve systems because you see people, you see interactions, you see the dynamic when you're on site, which is not possible yet virtually. Maintaining relationships and growing immersive medicine by cross-pollination. There are lots of systems that are insular and only learn from within. They are not the best systems. Then we ask ourselves, how much time have we spent with international peers in the past 12 months learning new things from outside your area? I would suggest that that has decreased remarkably. So what is the new normal? I don't have a clue. But we have to prepare for it. And I'm going to bring some things up that we need to think about when preparing for the new normal. Unlike with SARS, COVID-19 is not going away. We will have recurring pandemics because of global warming. Initial COVID-19 had low mortality rates, but the new variants have younger victims with a greater risk of severe disease. What will the next variant bring, or the next infection? We need to work with public health. I go to the hospital I work at now, despite COVID, there are people in the hallways side by side. We say that you can't tell who's got COVID because 30% are asymptomatic, and yet we have patients side by side in the hallways with no distancing, no social distancing. We know that routine hot screening areas should become standard. There should not be general waiting areas. We then ask ourselves, how do we create HVAC systems for isolation in low-income country EDs? Well, the answer is you open the windows. But for other places, how do you create proper single patient rooms with proper ventilation at a cost that exceeds the ability of most to pay? We have to accept that virtual education is in fact the norm. We need to rethink where live education is optimal, where it is safe. I look at intubation in my emergency department right now, where it's done by a team. There's a respiratory therapist and an emergency physician and 2 nurses who go into the room. We use video laryngoscopy to avoid contamination. We have the same RT intubating patients with the same doctor giving the medications, and there is no place for a learner to be involved because we want to succeed with first pass intubation. So where do those learners develop the experience to become part of that team? Can that happen in a virtual education? Can it be reproduced? One thing we can say though is that comprehensive coverage of a curriculum is guaranteed because I can produce any scenario or any disease in a virtual world, whereas in the clinical world, it's purely by chance what you get to see. Politics. When to intervene when revolutions fragment emergency medical care as they do in Yemen? What political role should national emergency medicine societies have in people's lifestyles, in pandemic policy versus economic policy, in prevention or public health with drunk driving, gun control, road traffic measures, vaccinations. When do we intervene when a healthcare system in another country does not allow emergency medicine care to attain a recommended minimal standard such as IFEM has established? So as we've just seen, it's far more than clinical care. The idea that someone wants to go into medicine and be just a doctor is almost a naive concept. Yes, the majority of us will be doctors, but way too many of us need to know business. We need to know healthcare systems. We need to know politics. We need to know economies. We need to know system advocacy. So I ask, who's being trained and who's put these points in anyone's core curriculum? EM today is almost unrecognizable compared to 30 years ago. What I see today is not at all what I saw at the start of my career. With nanotechnology, artificial intelligence, and virtual reality, it will change even more in the next decade. Pandemics have induced a new normal. So computerization, infectious disease, global warming are changing the landscape so quickly. You have to ask the question, who will establish the pathway that will allow us to adapt clinical practice and training programs as rapidly as will be required? This is the slide that scares me. I have read all of Ray Kurzweil's work, and even he was off by 7 years. He predicted that singularity moment would occur in 2035. It is now predicted for 2027. And a singularity moment is the paradigm moment when artificial intelligence abilities surpass those of humans worldwide. And the previous generation will not comprehend what the current generation is doing. How do we adapt our training programs to adapt to that monumental a change in our world? There will be an even greater societal schism because there will clearly be even more spectacularly the haves and the have-nots. Those who have access to this new technology versus those who do not. So rounding up, I've been asked to be the ghost of Christmas future, to predict where we are today and where this will lead us. I haven't given you answers, but I've raised many concerns. Things that you need to think about in Hong Kong as you move forward. I want to thank everybody for the honor of being invited to speak at this wonderful conference. I look forward to answering your questions in real time in just a few minutes. Thank you very much.
It's great. Thank you, Jim, for the interesting talk. And you've covered a lot of range of aspects, including our role in EM, in preparedness, in prevention, in public education and public health. You're right in mentioning that COVID will change and will provide us with a new normal. We've seen SARS impacting Hong Kong, and masking became routine in the hospital after SARS. And it changed the hospital system forever. So the way that we build build hospitals in the future, the way we look at AI, even in IFEM, I think how the global grand rounds and teaching have changed since COVID. It's also provided us with opportunities, but also threats. So Jim, unfortunately, has some technical problems joining us for now. So we'll probably keep the questions for him until a bit later on.